Hello, my name is Chantil Jeffreys, and I am a nurse practitioner working for the past 24 years at Gastro One in the Memphis, Tennessee area. And I'd like to welcome you to my podcast titled Liver Functions Demystified, a practical guide for APPs. As an APP clinical director who onboards our new APPs, I'm often asked, what is the best way to interpret liver enzyme results? And when should I start to look for MASLD and MASH? So to answer that question, as many of our patients with MASH are asymptomatic, it makes it important to understand and identify the patterns and levels of AST and ALT that should prompt a workup for MASH. One of the key indicators for a MASH workup is mild to moderate elevation of ALT and AST. This will typically be at a level of less than 300. The ALT is generally higher than the AST, especially in early disease. Another factor is persistent elevation lasting more than 6 months with no other identifiable causes. But you shouldn't look at the ALT and AST in isolation. You should also consider associated risk factors of metabolic syndrome, like type 2 diabetes, obesity, hypertension, and hyperlipidemia. In these cases, even very mild elevations of ALT should warrant further evaluation. There are other liver enzymes that offer valuable insights into MASH and its potential severity. In the setting of MASH, elevated GGT may reflect bile duct involvement or oxidative stress, which are associated with disease progression. A high GGT in metabolic syndrome may also correlate with insulin-resistant and liver fat accumulation. Mild elevations in alkaline phosphatase may occur due to cholestasis or bile duct compression from hepatic steatosis. Persistent elevations in alkaline phosphatase may suggest progression towards fibrosis or overlap with other liver conditions. Bilirubin levels are generally normal in early stages of MASH, and elevated bilirubin may indicate liver dysfunction or impaired excretion. Low albumin levels or prolonged PT and INR may indicate advanced fibrosis or cirrhosis. So how do you differentiate liver function abnormalities potentially caused by MASH versus other common etiologies? An hepatocellular pattern includes elevation of both ALT and AST with normal to mildly elevated GGT and normal to elevated bilirubin. This can occur with MASH, with viral hepatitis, alcohol, and also with certain drugs. One key factor to differentiate MASH from alcohol-associated liver disease is the fact that the AST is often higher than the ALT, usually at a ratio of greater than 2. The GGT is typically elevated, and you may see macrocytosis on the CBC. So there will be an elevation of the MCV, which is usually greater than 100. In viral hepatitis, there's generally marked elevation in both ALT and AST, often greater than 500. The bilirubin may be elevated in acute cases, and of course, you will see positive serological markers. Drug-induced liver injury may exhibit a disproportional elevation of alkaline phosphatase and GGT. Serial monitoring of liver functions is important when managing patients with MASH who are undergoing lifestyle or pharmacological interventions. A gradual reduction in ALT suggests reduced hepatocellular injury. Normalization of GGT may reflect reduced oxidative stress and improved function. Signs of disease progression include rising of the AST to be greater than the ALT, which can indicate fibrosis advancement. Elevated alkaline phosphatase and bilirubin levels can also indicate worsening liver function, and a decline in the albumin or prolongation of PT-INR reflects synthetic dysfunction and progression to advanced fibrosis. These markers should not be viewed in isolation and should be considered along with fibrosis scoring to help monitor patient status. I hope this short video helped to demystify the evaluation of liver functions, especially in the setting of MASH. And I want to thank you for your attention, and please contact me if you have any questions.